All right, so visual snow, a lot of symptoms associated with venous congestion, possible cerebrospinal fluid leak. Come on up over here, please. Get close. So there's a few vascular anomalies and anatomical variants that set you up. So here, I'm going to remove this. So basically, we have injuries in the front of the throat here. You can see the hyoid is crooked, and you're not able to see that the thyroid, you actually have a broken voice box in there. And we do have an image of the airway as it goes through the voice box, how it's twisted about 45 degrees. So that's some interesting stuff. So you've had some trauma from all the MMA stuff. But the big thing that we're dealing with now is that we have these long calcifications of a stylohyoid ligament. So there's a rope, a ligament type of structure that goes from the skull down to the hyoid. And in your case, it's grown all the way down to here. It's on both sides. Now they grow a little bit differently. This one's particularly close than this one. So when you bring your chin down, this is going to pinch off pretty quick. And actually, this is not really showing the artery, but it'll pinch off the carotid artery, which is the main blood supply, and the jugular vein. Now, in your case, it gets 2 for the price of 1. You really only have 1 functional jugular vein. The left one is hypoplastic and really not there hardly. So this is functioning like 2 jugular veins. And this is what's getting pinched as soon as you bring your chin down pretty quickly. So it's bordered pretty quickly. It's been going on for a while. So we see some other interesting stuff. We see your veins trying to pop out of the back of your skull. So these are typically very small veins in there that you don't really see them very well. But in your case, we're seeing this adaptation, and all the blood's trying to get out. Now, when you were doing the dips and you had that thunderclap headache that occurred like that, when you were doing a weighted dip, your heart rate was up and your head was now we don't know if your head was down, probably was down. So we have high pressure blood supply getting in, the arteries are high pressure, blood gets in, and it didn't drain very well. So you brought your head down, you occluded this, and you got that thunderclap headache. So what happened? Was there a traumatic adaptation of these blood vessels quickly, and all of a sudden, did all this dilation occur like that? Or was it over time, slowly dilating? Now, there is an event when there is a name of an event that occurs, and it's called a AV fistula. So some of these traumatic prolonged Valsalva maneuvers can cause an AV fistula. That's where the connection between the artery and the vein gets blown. It is on our radar that it could be that. It could have just been an acute trauma, vascular trauma, that this dilated quickly, and that's what gave you your symptoms. There are nerves that run through here. They're competing for space with nerves and other structures. Then the other little caveat is that you've got this little calcification back here on one side. So when you were doing the dips, if your head was an extension, it would have pushed this atlas up a certain direction. And so that might be the thunderclap headache too. I don't know. I'm trying to figure out what happened through that traumatic event. Either way, we have some interesting anatomy in here that makes it to where you have a common injury like the rest of us. You're going to have an uncommon presentation. So let's run through the screenshots that tells the story. And you're able to see this okay?
Yes.
All right, so pathology stands on a 3-legged stool. You have to have 3 things wrong before you start having symptoms. It's just a rule of thumb. So this deviated septum, people typically sleep with their mouth open. It compromises any extra venous drainage back in there. So it's not good to have to sleep with your mouth open with a deviated septum. That kind of is what happens. The brain wants oxygen, and it wants blood in and blood out. So we're seeing a few things that have been going on. Here in this view, you only see one jugular. You don't see the other one just because this is an arterial phase, but still there's almost really very little drainage out of the left jugular. Unless you turn your head, it opens up a little bit. All right, so what are your vascular anomalies that kind of set you up? Okay, so what happens is that people will have they're born with certain things, and you're not sure if it's actually causing the problem or not causing the problem, because they were just born with it, right? So you have these interesting blood vessels The vertebral artery on the left is so small, so hypoplastic. There it is, very thin. And on the right, it's large, like my finger, almost. But on this side, it's real thin. So since we did an inventory, you know, if you were wrestling or something and somebody put you in a shoulder hold or something and push this down, I can see how you wouldn't have much blood supply going through there. This is all theoretical. This is just looking at these structures, wondering what would it take to cause that to give symptoms, because it is a very hypoplastic artery. So here's another shot. We see the large artery on the right. You don't really see it much on the left. You see the large jugular on the right. You don't see it very much on the left. Yeah. Okay. All right, so let's move through there. Oh, and by the way, that when you were doing a dip and this rock would have been in there, and when you brought your head into extension, it would have caused this to rock up this way. The atlas is shaped as though it's holding a sphere and standing on a sphere. I get to be a hero by adjusting this a lot, and this is a really critical area. It's a natural choke point. It's a place that people get injured. So just picture you got this one vertebral artery doing the job of both, just like you do with the jugular. And again, you were born with this stuff. It probably wasn't giving you any symptoms until you get a neck injury. Then it plays out a little bit differently than people with redundancies. Anyway, so it doesn't take a rocket scientist to figure if you had your head back, this thing would have rocked up, and maybe that had something to do with it. Either way, I don't like you to turn your head to the left. I don't like you to turn your head to the right. I don't want you to put your head in extension. I don't want you to bring your head down. Other than that, I think you'll be fine. Right. So, and when we see these things, to clinically correlate them, you do physical exams and you do experiments. You're going to stop moving your head around. It would be nice if you wore a collar a little bit to see, maybe just sleep in it or something, play with it. You're going to find out what's going on there. So this is that vertebral artery as it comes across. Now, I've seen them be in pretty bad spots. Yours seems like it's okay. So we're just going to kind of gloss past that. Although this is your venous drainage on the right side that's robust, and on the left side, robust. Robust means good, full, but there's another shot of it. It's dominant. We'll call it dominant, as if we're trying to get 2 out of 1, and it's not enough. So your symptoms are basically, and there's another extra little holes in the head where your veins are trying to adapt and leave. There we go. So when we see them large like that, we comment on that. There's the styloid atlas. So you're going to end up probably getting that styloid removed and getting the atlas shaved down a little bit. And do I think your nurse and CSF leaks? Absolutely. And there's the other side, that left side that I was talking about. Another shot of the left side. Those are very long. They're almost all the way down. They're trying to fuse. Okay, so when you bring your chin down, the artery is going to be on this side. Actually, so at one point that stylo would have been trying to puncture the artery when you bring your head down, but it's gone past that. It's down to here. So when you bring your chin down, you're going to be choking off the one jugular vein that you have and actually put pressure on the internal carotid. The left one, there's a little more room in there. It doesn't come down as quickly. So there's that. Okay. Oh, I ended up measuring how far was not calcified. So 1.5 centimeters is not calcified because the hyoid is, this end of the stylohyoid ligament is calcifying up to about there. This one's gone all the way down. And when I do a physical exam on you, the muscles at the cervical cranial junction, they're not doing what they're supposed to be doing. They're angry, upset, large, swollen, involved. And I think it's secondary to try to moving these tusks around inside your anterior compartment. Yeah, there's that view of that coming down pretty quickly. We're looking up from the bottom. Yeah, if you can make sure we're good on that. Okay, and that's it. That's kind of the main thing. This is a side view showing how the carotid artery is right next to the styloid pretty quickly. And we did draw some lines to try to figure out how to put your atlas in place and get this thing reduced. We always like to get all the muscles and the swelling to go down and open up a jugular vein. And we had some Well, like you would expect, we helped some, but the surgeon's going to be the big hero in this case. Here you can see that dilation there. You can see the jugular there. And then we put the atlas in place, or place the atlas. And these slight rotations and anterior movements, these are the things that I spent a lot of time trying to figure out exactly how to reduce. Again, we're showing how the carotid artery is also not placed the same. Does it play out? Well, we went in the back of your throat, and we went after some of these muscles in here. We've seen these arteries get compromised by injuries in the front here. We're calling it a compartment syndrome, an atlas compartment syndrome, because it has some similarities with a typical compartment syndrome, but it's a little different because the anatomy is different. So we're still trying to understand that. Yeah, showing the distances. Yeah. Left head rotation, right head rotation as they swing around, swing through there. Left head rotation, right head rotation. Yeah, it does bottom out. That calcification does hit the bottom of the skull. Right, so the question is, are these calcified styloids an attempt to stabilize a hypermobile upper cervical spine? Well, they're so calcified, it could be covering it. But this does wag, your odontoid does wag back and forth on your atlas about a millimeter, a little over a millimeter, 1.25 millimeters, something like that, which is not very much movement in there. Are you a little loose up in here? I think so, but again, no smoking gun. I can't say that's what's causing your symptoms, and my sense is that that's not what's causing your symptoms. This is left head rotation. Again, it was mostly important to me figuring out how this thing is moving incorrectly because of the mechanical loads that are being put on it or have been put on it. Right head rotation. Left neutral, right head rotation. This really matters more to a clinician that's going after you. Another shot of it. There's only a 1.5 millimeter gap there, so there's not a lot at all. That's the maximum distance it could go, and it doesn't seem like it's going. So I call it 1.25. Right, so what did we do today that actually gave you some results? We went in through the back of your mouth and we went after these muscles in the front there, and it loosened you up and you felt a little, some stuff was better. Not all of your symptoms are, well, I think you have a buildup of metabolites. The brain's very metabolic, it gives off waste products, and those metabolites can be inflammatory if they're not drained efficiently, and you're not going to be able to drain efficiently with that that venous system that you have that's been injured. You know, it wasn't great to begin with, and then once it got injured, I think that's where you are. So the visual snow and some of these other things, I think there's an inflammatory situation going on in the brain from the buildup of metabolites, and that's what we've got. This is a good view of that injured voice box. There's the airway. This is an airway study showing how it's twisted by about 45 degrees. Yeah, that's it.
Thank you.
Okay. Any questions? Anything you want me to talk about?
I think that covered pretty well the main things we discussed and what we saw on the film. And I just appreciate your time and thank you so much.
My pleasure.